Hello and welcome to another emergency questions and answers for families in intensive care and intensive care at home. Thank you so much for joining the call, and also thank you for those of you that watch this on replay. I know it also gets a lot of views on replay, so I want to thank you all for your support. Keep the questions coming. I'm your host. My name is Patrick Hutzel, founder of intensivecarehotline.com and founder and director of intensivecarehome.com. What makes me qualified to host an emergency questions and answers for families in intensive care and intensive care at home? I am a critical care nurse by background, and I've worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years, and I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can confidently say that we have saved many lives with our consulting and advocacy at intensivecarehotline.com, right? And you can verify that when you go to intensivecarehotline.com. If you click on our testimonial section, or you go to intensivecarehotline.com and you click on our podcast section where we've done client interviews verifying the work that we've done. You can even, watch a video where we have an ex-ICU patient there who was told in ICU, and his family was told, he's going to die, he's not going to survive. And a year later, he sits on a podcast with me and his family, right? That's how far it goes. And that's also one of the reasons why you always need to question. Always need to question. If you don't get a second opinion when you have a loved one critically ill in intensive care, that's like, flying an airplane with a cabin crew instead of the pilot, right? It's like driving a car without a seatbelt, right? You are in a once-in-a-lifetime situation that you simply can't afford to get wrong. That's how bad it is. Now, I'm also the founder and managing director of Intensive Care at Home, and you can find more information at intensivecarehome.com. With Intensive Care at Home, we are currently sending our critical care nurses into the home for long-term ventilated adults and children with tracheostomy, but also home BiPAP, home CPAP, tracheostomy care without ventilation, home TPN, home IV potassium, home IV magnesium, Hickman's line, PICC line, central line management, and port management at home. We're also providing palliative care. We're also sending our critical care nurses into the home for emergency department bypass services. And we're cutting the cost of an emergency department admission by $2,000. We're cutting the cost of a $5,000 to $6,000 per bed day intensive care bed to around 50% of that. With Intensive Care at Home, we're currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are NDIS approved, TIC, WorkSafe in Victoria, ICARE in New South Wales, NIISQ in Queensland, as well as the DVA all around Australia. We're employing hundreds of years of intensive care nursing experience combined in the community. No other provider in Australia brings that level of expertise in the community. And we're also the only service in Australia that has achieved third-party accreditation for intensive care at home nursing. No other provider has created the intellectual property around that than we did, and we do. Okay, without further ado, let's go to the first question. But if you have questions, type them into the chat pad or join me live on the StreamYard link here. You can talk to me directly here. This is your opportunity to get some free consulting. We are probably going for a good hour. I usually go for a good hour. So get your questions in now while you can. And you're welcome to talk to me. Okay, first question. It's actually not a question today. It's actually a testimonial from Crystal. I want to read out Crystal's testimonial. So, hi Patrick. Thank you and your team so very much for your assistance to us, for my mother-in-law, in your knowledge, care, and updates. Your assistance helped us to be knowledgeable, to converse with the doctors about everything going on with her. So what we were doing for this particular member was that we were reviewing the medical records as part of our membership and giving her a second opinion, giving her updates, guiding her and her family what questions to ask, what to look for, right, and so forth. That's part of our membership. No, now, Crystal continues. If we didn't have your help, then they would have just called her brain dead and pulled the plug after her stroke. She has continued to improve, and we know now what to ask and keep helping her at home. Thank you again so very much for your service. This is so much needed by all dealing with intensive care and ICU teams. From Crystal. Well, thank you so much, Crystal, for your feedback and for your testimonial. And, it's actually quite timely. My last quick tip that I published on YouTube just in the last few hours was actually also about someone being declared brain dead in Kentucky, and they woke up just before apparently they were donating organs. So the last quick tip that I put up there is, man declared brain dead wakes up as organs about to be removed. So this seems to be a common occurrence, and I've warned about this for many years here and on my videos at intensivecarehotline.com. I've warned about this for many years, that if intensive care teams come to you and say, your family member is brain dead, well, where's the evidence for that? Show me the evidence. So this is just in the last 24 hours now, 2 people basically saying, well, my family member was brain dead. And the minute we asked for evidence, they didn't have any. Right? You have to question everything. When you have a loved one in intensive care, you are in a once-in-a-lifetime situation that you simply cannot afford to get wrong. You just can't. Right? I think, and here's another warning with brain dead in particular, right? Or brain death, I should say. When intensive care teams tell you, oh, your loved one is brain dead, and they're not, then they might be brain damaged. They might. Right? You better find out. If someone is brain damaged, that is not the equivalent to someone being brain dead. It is not the equivalent. Many families in intensive care mix up terminology, and they think because my loved one is brain damaged that they're brain dead. It's not. They're 2 very different things. Whilst they are related, they're 2 very different things. Right? When someone is brain dead, they stop breathing. They stopped having any reflexes. Right? Their organs might be working, but the brain is no longer working. Right? Here is another important aspect of someone being quote unquote brain dead. In most jurisdictions around the world, right, when someone is quote unquote brain dead, they are also legally dead. Now, what does that mean? If ICUs have tested for brain death and they have come to the conclusion by 2 independent doctors that this person is brain dead, they can issue a certificate, which means they are legally dead. Right? So, I am not here to make any judgment about this whatsoever. Right? I will tell you the following, though. Depending on your culture, religion, beliefs, whatever the case may be, you might say, well, I don't want to go along with that. I believe just because they are saying my loved one is brain dead, I believe they're still alive. Right? So, what does that mean? Well, it means that you don't accept that someone who's quote unquote brain dead is legally dead. You don't agree with that because maybe your culture, your religion, your spiritual beliefs, whatever the case may be, don't align with that. And then you need to speak up. I'll give you another example. In 2013, there was a case in California. The patient was J.I. McMahon, J-A-H-I, Megma, M-C-M-A-T-H. She was a 13-year-old girl in California who had a tonsillectomy, a removal of her tonsils. And sadly, she had a post-operative bleed, and she ended up with a massive bleed, and she ended up with a cardiac arrest. And there were many complications, and afterwards, the intensive care team did the brain death testing, and they said she's brain dead. Now, the family didn't accept that. She was a 13-year-old girl, right? And they went to court. When they went to court, the court ruled that the family has the opportunity to get a tracheostomy and move her to another state. They moved her to New Jersey because apparently in New Jersey, when someone is brain dead, they're not legally dead, right? So you have to look at the fine print. And Jaya Megma lived for another few years in New Jersey, and there are videos online about her where you can clearly see that she's not brain dead. You know, she was interacting with her family. Once again, you have to question everything when you have a loved one critically ill in intensive care. The goal for intensive care and critical care units are to empty their beds as quickly as possible, to save money, maximize revenue, right, and drive a narrative about negativity, about doom and gloom, right, that puts them in the driver's seat. What does that mean? ICUs are trying to protect their downside. So what do I mean by that? So when you have a loved one in intensive care, you will very quickly see that the intensive care teams are driving the doom and gloom, that it's all hopeless, that your loved one won't survive. If they do survive, they won't have any quality of life, you know, and that it would be, quote unquote, in your loved one's best interest just to stop life support, stop treatment, withdraw treatment, and let them die, because that is the most humane thing to do. And I object that with all of my core. I object that with all of my core. And life is sacred, and we have to be the protectors of life, right? I've done a video recently. What's the hurry to kill someone in intensive care? I encourage you to watch it, right? What's the hurry to kill someone in intensive care? Tell me. What is the hurry to kill someone in intensive care? I want to know, right? So by them driving the doom and gloom narrative, by them being negative, you know, if your loved one isn't improving, they can tell you, I told you so. By them, you know, creating this narrative of doom and gloom and end of life, and, you know, it's not in your loved one's interest to continue treatment, blah, blah, blah. Once again, they're creating this narrative, and it'll be much more difficult for you to challenge it unless you have a professional like myself and my team on site that can help you with challenging them, that can help you with advocacy and consulting, that can handhold you through this process, because you have to understand intensive care inside out to challenge them appropriately, right? So also what they're not telling you is that 90% of patients in intensive care actually survive. It's 90% of patients in intensive care that are surviving. They're not telling you that. They're making it look like 90% of intensive care patients are actually dying in intensive care, which is not accurate. So, you know, I don't want you to be one of those families who comes to us and says, hey, I lost my loved one last year in intensive care. The intensive care team said, there's no chance of survival. Let's just stop everything. And they followed suit without getting a second opinion. And then, you know, once the dust has settled, they start doing their research. Then they come to intensivecarehotline.com, and then they realize that probably would have been another option, right? But then it's too late. And then they want a medical record review, and then they want a second opinion when it's too late. Has there been any negligence? Most of the time we do find there has been negligence. Most of the time we do find it was a perceived and not a real end-of-life situation. Let me repeat that. Most of the time we are finding that it was a perceived end-of-life situation, not a real end-of-life situation. What's the difference? I'm glad you asked. A real end-of-life situation, let's start with a real end-of-life situation. A real end-of-life situation is a end-of-life situation in intensive care where the clock is ticking, no treatment, no surgery, no fancy drugs, no equipment, no doctors, no nurses can save your loved one's life. That is a real end-of-life situation and not a perceived end-of-life situation. So, a perceived end-of-life situation is just that. It's perceived. It's not real. Okay? So, the intensive care team wants to give you the perception that it is an end-of-life situation. And they're the master at it. They are the master at it. Right? To make you want to believe that your loved one is dying. And they're not, because treatment, care, equipment, maybe surgery, medications can help to turn this situation around. Is there a guarantee? No, of course not. No guarantees. But if you don't try, you know the outcome anyway. Right? I just wanted to highlight that once again, because it is so important that you understand why intensive care teams are in a doom and gloom mindset. That's number one. And number two, you need to understand what the options are, and that 90% of intensive care patients actually survive. Now, let's get to the next email. If you have any questions, type them into the chat pad or join me live on the StreamYard link here. You can click on the link. You don't have to go on camera. You can just talk to me anyway. Okay, so I've got an email here from Sonia, who says, "Hi, Patrick. It was an honor to speak with you in person today briefly. I'm figuring what plan I can get and just got home from the hospital. I doubt they will go through with the extubation operation, as I believe the hospital needs some or most of the ability checks passed. Now, extubation is not an operation. Extubation is just a very straightforward procedure. It's a removal of a breathing tube in the mouth, in the throat. That's what it is. It's not a surgical procedure. It's just a removal. The important thing, though, with a removal of the breathing tube or extubation is that you do it at the right time so that a patient can breathe spontaneously and so you don't have to re-intubate them. So it's an actual skill that ICU doctors and nurses need to have to extubate at the right time. So then Sonia continues. My mum is lightly in lignocaine and heparin. Came into ER in atrial fibrillation. She got converted the next morning. She thrashed her arms, IVs, wrong placed balloon, and had a cardiac arrest and CPR. Wow. Meds changing place. Wow. So she would have been on a balloon pump. So let me just quickly explain about a balloon pump. What a balloon pump is, especially for cardiac failure. A balloon pump is inserted through the groin and sits right in front of the coronary arteries. It sits in front of the arteries at the heart, and it helps oxygenate a weak heart. That's what the balloon pump does in a nutshell. But it was incorrectly placed. Wow, that's a challenge. And of course, she would have had a cardiac arrest then. Wow. Okay, so then she continues. Medications were changed, questioned due to her CYP2D6 deficiency. had citroprol and the amiodarone. Yes, amiodarone would have been for AFib. And another short cardiac arrest from the clot in the lungs, from prior CPR, and couldn't cough it up, and got a one-hit wonder back to life. She got intubated then. She came from memory care on the cusp of moving her out. I believe sedatives were in her system and not properly assessed. Her meds at the facility, and an incident which is another topic, but along the lines of her stressful breathing. Low breaths to find out she was in AFib, atrial fibrillation, upon arrival to the emergency room. She continues, hospice hounded us and said tonight they were ready to do the extubation 1 hour after they got my dad to sign hospice Medicare papers and sign on. No paperwork, nothing for us about the procedure, and 3 days ago we said tentatively planned for Saturday, which is tomorrow. We clearly knew that. Now let's just stop here. Can you see the words that Sonia is using? Hospice hounded us and said tonight they were ready to extubate 1 hour after they got my dad to sign hospice Medicare papers and sign on. Now, hospice, what does hospice mean? Hospice means basically you're moving someone from ICU to hospice to let them die. Once again, what did I just say a minute ago? I made a video a few weeks ago. What's the hurry or the urgency to kill someone in intensive care? Which is exactly what we're dealing with here. What's the hurry? What's the urgency to kill someone? Please explain that to me. I'd be curious to hear your comments as well. Plenty of time to talk about end of life. Now, it's getting worse, right? I'm not continuing with the email yet, but just on that note, there was a documentary on CBC in 2023 around August or September, so about 12 or 15 months ago, US CBC, I should say. And the documentary pretty much revealed that some hospitals in the US get paid incentives to move patients from ICU to hospice and let them die. Let me repeat that. Some hospitals in the US get incentivized by some healthcare insurances to move patients from ICU to hospice and let them die. And to top it all off, the patients that die don't even show up in the mortality rate of the hospital, making the numbers really look good. Now, this is not me saying that. This is CBC journalists investigating and saying that. This is absolutely shocking and needs to be exposed at the highest levels, right? So that's just to illustrate the environment we're currently in, right? That's just the environment we're currently in. Where are our religious leaders speaking up against this insanity? Where are they? We need to protect life at all cost. Okay, let's continue with Sonia's email. No paperwork, nothing for us about the procedure. And 3 days ago, we said tentatively planned for Saturday, which is tomorrow. We clearly knew that. Talked to her yesterday at length of my distrustments. And today, the coordinating social worker, and can't believe she says, we just forgot about that. I wanted a breakdown of procedures. I also ordered an EEG and stated I wanted that for my comfort. And the nurse said message was sent and the neurologist is coming in the morning to do that now. And I'm guessing the results will be the day after, but I'm offended or feel like it was a slap in my face for them to think we would just do it tonight. And if it was some sort of push to close the deal, game, or let's make sure they won't change mind, deal. I can't believe their mentality is below a preschooler who would understand our understandings. The push was strange. There's other things that are contradictory, but I don't want to spill my heart out here more about the other pertaining issues. I wanted to let you know I'm unable to ask of a reserved time tonight. I'm embarrassed to say I have to have a clear mind. I really respect and appreciate the advocacy work you do, and I look up to that. I was on a mission of battling proper care and fighting with my mum in fancy facility farce, but it looks like now here, still the farce spills all the way to after her life was saved, just to end it. Alzheimer's and aging gets the discrimination glory hat of unworthiness attitude. Whereas I believe it's a mentality, and my mum was actually getting better and was still so cute and loving and lonely. And when we weren't there, but she was hopeful and had life in her. I don't like the contradictions in what's being proposed. I asked day after her second CPR, a short one-hit wonder. I thought she just needed to rest from the chest beat up and detoxify from the improper meds in her system. Her heart rate and vitals and body is functioning like had 3 bowel movements, urine looks clear, and worried she's still fighting. They say, well, look at what her life will be like. She was dying anyway, they say. It doesn't feel right. I have copy of her medical records. I appreciate your words and message. We only have one time to make sure we're right. So I'm telling my dad I'm reaching out to you for confirmation and reassurance aside from there's no other way, as they are putting it. I might have their support tomorrow. I'm going to forward this to my aunts, my uncle, my mum's brothers and sisters, as well as to my eldest of 3 brothers. Sincerely, from Sonia. Well, Sonia, I'm glad you're catching on to things now. Better late than never. But can you see how euphemistic they want to make it look like when they kill someone? You know, let's do a quick and easy extubation and let's wash our hands clean. That's how bad it is. Now, yesterday, we've been consulting this one client for the last couple of weeks, and she has her sister in ICU after a stroke and cardiac arrest. And of course, her and her family were told she won't make it, she won't wake up, she won't survive, she's got brain damage, and that it's inhumane and cruel to continue treating her, right? And 2 weeks later, she's waking up and she's, moving everything on purpose, right? And she can now respond to yes and no questions. Now, what have I been saying here for the last 10 or 11 years here at intensivecarehotline.com? Been saying that recovery in intensive care takes time, and it takes a lot of time, right? So if you don't give patients that time, well, they're not going to recover, right? 2 days in ICU is not a long time. 4 days in ICU, not a long time. 14 days in ICU may not be a long time, right? So you need to understand what time means in ICU, because if you don't understand that, once again, you're fighting an uphill battle. I've seen patients in ICU for as long as 18 months, right? And if intensive care teams don't want to give, families the time, then what's the point? What's the point? I have another email here from Katie, but I would like your opinions. Do you think it's ethical, moral to move towards end of life very quickly in ICU. Do you think that families are always getting told the truth when they have a loved one critically ill in intensive care? Do you agree with that? What's your take? Leave your comments. Okay, so I have another email here from Katie. Hi, Patrick. I found you a little too late, I fear. My brother's 2.5-month-old, born in August 24, photo attached, suddenly stopped breathing 2 weeks ago and then went into cardiac arrest. He had no known health issues before that, and we don't know the cause. The hospital say it was asphyxiation with unknown cause. His mother had been breastfeeding him at the time when it all happened. They were in a cafe and happened to be with a friend who is a trained nurse, so she gave him immediate CPR and the air ambulance came fast. They took him to Cardiff Heath Hospital, where he has been now for nearly 2 weeks. It's been a roller coaster ride of seeming improvement and then being told he wouldn't survive as his brain damage appeared too extensive. I've had doubts all along about the advice they are receiving because it always seemed to directly counter what they were observing themselves. Daily improvements in Sophia as he came out of sedation, eye-opening, legs and arms moving, improvements in his breathing, etc. Then last Saturday, the doctors made a decision to give him phenobarbital, and all these improvements stopped. His breathing worsened and he stopped moving again. They told the parents on Tuesday that there was no hope of survival and they were in an end-of-life care situation now, and that he wouldn't be able to breathe on his own and would need to make the decision to turn off his ventilator. This is for a 2.5-month-old baby. Let's ask the question again that I like to keep asking. What's the hurry to kill a patient in intensive care? What's the hurry? What's the hurry to kill a 2.5-month-old baby? They have pretty much been saying that from the outset, so it didn't surprise me, but I do believe that the phenobarbital was still playing a big part in his lack of response and brain activity when they made the decision, especially as it's in combination with morphine and other medications. I would have shared your details with my brother, but I felt it's too late. He had already made his decision and they took him off the ventilator on Thursday night. He didn't stop breathing instantly as expected. By yesterday evening, he was still with us. I don't know what's happened overnight, but the expectation is that he will gradually stop breathing. So I don't think you can help us now, but I will let you know if anything changes. Thank you for the work you do. It still gives me some comfort knowing you are out there helping families in our situation. Warmest wishes from Katie. And she attaches a picture of her nephew. Beautiful child, beautiful child. I can't comment on the phenobarbital. I would need to look on through the medical records to, make an informed comment there. If he was waking up, I don't see the need for giving phenobarbital, but there could be other things as well. I don't know without looking at the medical records. What I will say is this: similar to other cases that I discussed today on this call, there seems to be a real urgency from day one to move patients towards end of life as quickly as possible. Now, in this situation, the email from Katie, the context is that Katie is in the UK, and the UK has a track record of killing children in particular. UK has a track record of killing adults in ICU with euthanasia, especially during COVID. There's a research paper about that out there, actually, right? Type into Google, did ICUs euthanize patients during COVID with midazolam? Type that into Google and see what you get, right? So, especially with the killing of a child here, most likely we don't know if the child was still alive. There's a number of things. The first thing is, well, the child is still alive. That's the good news. So once again, you have to question the clinical judgment of intensive care teams. You absolutely do. Because if it is such a doom and gloom situation, why are we, why is the child alive? Why? And if the child is not dying now, what's happening from there? Is the child going to be euthanized? Right? So, this is also in the context of the NHS in the UK killing children such as Charlie Gard and Alfie Evans and others. Alfie Barasby was another one. There would have been at least 3, 4, or 5 children that the UK court decided the NHS can basically kill them because they had chronic illnesses and chronic diseases. And even though those children could have gone overseas for treatment, and the family raised money, or the families raised money for their children to get treatment either in Italy or in the Vatican or in the US, the UK courts basically decided that the NHS can, withdraw life support and let those kids die instead of giving them treatment in another country. It is unheard of, it is outrageous, and this email shows me that the UK continues on this path. Once again, where are our religious leaders here and speak up? How do we protect life coming into this world? How? We need to speak up against this insanity, right? Of killing children that are, quote unquote, in the eyes of the NHS or potentially of some doctors and even nurses, unworthy of living. This insanity needs to stop, right? Again, I'd like your comments. Do you agree with that? Do you disagree with that? What's your take on this? So let's move on to the next question. Or if you have any questions, please type them into the chat pad. Or click on the link for the StreamYard link and talk to me directly here. Right? So you can talk to me directly here. So let's move on to the next question. But, this is what we're up against in 2024. People are getting killed in ICU prematurely. Families are getting told it's all hopeless. There's services now at home, like intensive care at home. We can prolong life at home with intensive care at home, right? And still save the ICU bed because that's what the ICU wants. Why are we not reverting back to common sense? Okay, so here's another email from Deborah who says, "Hi Patrick, thank you for all of your videos. My family member had a cardiac arrest, had a heart attack, and his wife woke up in the middle of the night with him struggling to breathe. She thought he was having a nightmare and tried to wake him for a minute or so and then called 911. They told her to start CPR immediately. He started to turn blue when she started. The paramedics were there within 11 minutes of her doing CPR. Here we are at day 4. All of his organs are doing fine, but waiting on an MRI scan of the brain. Your videos give me hope. I'm not sure if it's an induced coma or not. What's the difference? Thank you so much for all your help. Right. So, well, if all of his organs are doing fine, I would argue that includes your family member's brain. If your family member's brain is working well and all other organs are working, well, they should just wake him up, get him out of the induced coma, if he is in an induced coma, and extubate him, right? So the major organs are heart, liver, kidney, lungs, and also the brain. So if all organs are working, that must include the brain. And if it does include the brain, well, nothing should stop your family member from waking up with or without an MRI, right? So the MRI should not be a make or break if he's waking up. If he's obeying commands, right? If you ask him to squeeze your hands, if you ask him to poke at his tongue, if you ask him to wiggle toes, and he's doing all of that, then there should be nothing in the way of waking him up and taking out the breathing tube, assuming he can swallow. However, if they were doing CPR for 11 minutes, there is a chance that there has been some brain damage. But if you are telling me all organs are fine, then that should include his brain, right? Why are they waiting for an MRI scan of the brain? It does make sense that they want to do one, but why have they not done it on admission? Why, or have they done a CT scan of the brain, right? So, once again, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care. That is, once again, exactly what you're up against here. So, let's just say all his organs are fine, including the brain. And let's just say he is in an induced coma. Let's just say he's on sedation with maybe midazolam/Versed, maybe with propofol, maybe with Presidex, maybe with a combination of all of those sedatives or some of them. Maybe he's on morphine, maybe he's on fentanyl, right? So if the brain is intact, what stops them from waking up, from waking your family member up? Nothing should stop them from waking him up. And what stops them from doing an MRI? What is it? Is he unstable? Is an MRI scanner not available? Is there not enough staff? What stops them? Right? I think it's critically important that your family member gets an MRI scan here, right? Another thing that might happen here is when they wake him up, is he having seizures? So if there's a level of brain damage after the cardiac arrest, this often shows up with seizures, right? Is that why they can't wake him up? Because when they wake him up, is he potentially having seizures or jerking movements, right? Another question that you need to answer here is, was he in cooling therapy? So after out of hospital cardiac arrest, often cooling therapy is commenced, right? And I want to find out, I want to know whether he has been in cooling therapy or not. Right? That is best practice, best standard, evidence-based. Also, do you have access to the medical records, right? We can very quickly give you a second opinion by you giving us access to the medical records, right? Now, you're also saying my videos give you hope. Now, I've got news for you. Hope is not a strategy. You need a strategy, not hope. You probably need both. Hope is good, But hope is not a strategy. If you don't have strategies when you have a family member in intensive care, you've got another thing coming. You'll have intensive care teams walking all over you. Right? So, and let's just say your family member is not in an induced coma, right? Then why, or is he waking up? If he's not waking up, I argue he urgently needs an MRI scan, right, to find out whether there has been brain damage. But once again, you're telling me all organs are fine, and I would include the brain into that, right? So let's move on to the next question. It's actually not a question, it's more of a comment, but I still think it's very relevant, highly relevant. Comment from Ivana. Hi, Patrick. Thank you for all your videos. I would like to know something. I spent 11 days in an induced coma in ICU after a suicide attempt when I overdosed on prescription medication. I remember being intubated and it was extremely traumatic, but I don't remember how I got to ICU and what really happened. Everything after I woke up, I'm not exactly sure what was a reality and what was not. But I have to have something in my mouth and moving, and then she puts 3 question marks there. And when I didn't, the computer went crazy and started beeping. But I'm not exactly certain what was a dream. I was apparently on fentanyl and propofol. I had to learn how to walk again, and my oxygen levels were low. I was delirious for another almost 2 months, but kind of in and out. But I spent only 5 days more in ICU after I woke up. And then they transferred me to a different ward in the hospital, and I spent another 2 months there because of delirium. I also had a pneumonia, but I don't know how I got it. Well, you probably got the pneumonia by being on a ventilator. Many patients in ICU get what's being referred to as a ventilator-associated pneumonia. That's most likely what you've had. Now, you've had something in your mouth and moving. Well, you probably had a breathing tube in your mouth, right? And when I didn't, the computer went crazy and started beeping. I don't know what you're referring to. I argue if you were in a propofol and fentanyl-induced coma, you were on a ventilator, you would have had a breathing tube in your mouth, and that's probably what you're referring to. Once you had the breathing tube out, maybe that's when the monitor went crazy because maybe you were moving around too much or you were thrashing around. I don't know. Not quite clear to me. But I guess what's good about your email is really that, you know, you have shown people that you are definitely, you know, that survival in intensive care is absolutely possible. You know. So yeah, thank you so much for sharing this with us. Okay, so let's move on to the next question. And if you have any questions in the meantime, please type them into the chat pad or join me live on the StreamYard link here. Here is another comment from Doris who says, the ICU doctors are saying my mom will never wake up. Okay, that's quite a common comment for families in intensive care or for doctors in intensive care. It's quite a common comment to make. My question is, what's the evidence? Do you remember in the beginning I talked about someone being brain dead and they weren't brain dead? Right? Where's the evidence? Please show me evidence. It's just a comment, it's just words. Intensive care teams are notoriously bad at predicting the future. They're very good at saving lives, very good at predicting what's happening while someone is in ICU. They're very poor at predicting what's happening after intensive care. Very poor at predicting that. Case in point. So with intensive care at home, and you can find more information at intensivecareathome.com, we are looking after a number of long-term ventilated adults and children in the community with tracheostomies, right? Some of the conditions we're looking after are spinal injuries, C1, C2, spinal injuries, C4, C5, spinal injuries, right? People being ventilator tracheostomy dependent, some patients being CPAP or BiPAP dependent without a tracheostomy. We're looking after patients with a tracheostomy without ventilation. We're looking after patients on ventilation with tracheostomy with MND, motor neuron disease, or cerebral palsy. You know what these families and patients all have in common? They've all been told multiple times that their family member won't survive. If they do survive, it would be cruel and they won't have any quality of life. Now, I encourage you to ask those patients and families how they feel about their current quality of life and whether they want to live or not want to live. Now, I can assure you that all of them have chosen life over death. And yet, intensive care teams want to create the narrative of, it's in your quote unquote best interest to die. Right? It's inhumane letting you live. How did we get to this? How did we get to this? That it's inhumane to live, but it's humane to die. How did we get to this in 2024? End-of-life discussions have their time and their place, don't get me wrong. But when patients and families come to us, that's all they've been told. Right? That's all they've been told. And it's wrong. And it's wrong. So, I got to wrap this up in a minute. I want to thank you for your attendance. And I want to thank you for the questions that have come in via email. Obviously no one wants to talk to me today here on the show. What a shame. But that's okay. Keep the questions coming via email. Now, with Intensive Care Hotline, like I said, we've got a membership for families of critically ill patients in intensive care. I do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I handhold you through this once-in-a-lifetime situation that you simply cannot afford to get wrong. Right? I talk to doctors and nurses directly. I ask all the questions that you haven't even considered asking. I hold them accountable with my questions. I represent you in family meetings with intensive care teams. We do medical record reviews in real time. And we also do medical record so that you can get a second opinion in real time. We also do medical record reviews after intensive care. If you have unanswered questions, if you need closure, or if you are suspecting medical negligence. Now, also, if you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, share the video with your friends and families, and comment below what you think about these topics, whether you want to hear more of it or whether you want to have other topics covered. With intensive care at home, like I said, we are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are NDIS accredited, TAC and WorkSafe in Victoria, ICARE in New South Wales, as well as NIISQ in Queensland, DVA all around the country. Our clients have received funding through departments of health, public hospitals, as well as private health insurance. We have always been successfully involved in the advocacy for our clients from day one. Otherwise, we wouldn't be in business. So if you're looking for advocacy, if you are stuck in hospital or in ICU long term, or you're at home already, and you don't have the right level of support, word of warning, the support worker model for basically ICU patients on ventilation with tracheostomy at home. Many patients have died, and I have evidence for everything that I'm saying here. I can back it up. Right? So if you need more funding and you need critical care nurses, which is what is evidence-based, right, we can help you with the funding once again, otherwise we wouldn't be in business. That's also why we're providing level 2 and level 3 NDIS support coordination. We have a team of NDIS support coordinators, level 2 and level 3. And we're also providing TAC case management in Victoria, TAC and WorkSafe case management in Victoria. If you are an NDIS support coordinator watching this and you need more nursing care for your clients, or you need more advocacy because you don't know how to go about the nursing care for the NDIS or for other funding bodies, please contact us. We also do NDIS nursing assessments with our critical care nurses. Most of them have a legal nurse consulting background as well. If you're a critical care nurse looking for a career change, contact us with Intensive Care at Home. We currently have jobs in Brisbane, Sydney, Melbourne, Albury, Wodonga, Bendigo, Warragul, as well as Geelong. If you want to work for us as a critical care nurse, please note that we're not an agency, we are a service provider, and we have a tailor-made solution for our clients, which means we're looking for regular staff. Do not contact us if you're looking for agency work where you want to come and go. Our clients want regular staff with regular teams. That is part of our promise. It's part of the tailor-made solution we are offering. If you're an intensive care specialist or an ED specialist, we're also currently expanding our medical team. We want to hear from you if you are interested in working for us. If you're working in ICU or in ED as an intensivist ED consultant, we also want to hear from you. We can help you eliminate your your bed blocks, right? And you won't even pay for it, right? And we improve the quality of life for your patients and families at home, and we help you empty your beds. If you're a hospital executive watching this, and you have bed blocks in your hospital, we want to hear from you. We can help you free up bed blocks in ICU and ED. If you're in the US or in the UK watching this and you need help with intensive care at home, I encourage you to reach out to us at intensivecareathome.com. Call us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com. We can help you in the US and in the UK privately. Thank you so much for watching. Once again, give the video a thumbs up, subscribe to my YouTube channel, and share this video with your friends and families, and leave your comments below. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com and intensivecarehotline.com, and I will talk to you in a few days. Take care for now.